Good afternoon, boys and girls. It's great to have you here. Thank you for coming out on this beautiful afternoon. This is the third of this year's Voices from the Vanguard lecture series. It's the 6th year that my partner in crime, Dan Colley, who's sitting down here in the front row, and I've done this. Dan is a microbiology professor, and he's the head of the Center for Tropical and Emerging Global Diseases here at UGA. Well, it is the whole world. Dázon's gotten me thinking global today. And I'm Pat Thomas, and I teach health and medical journalism at Grady College. This is a blue card event, right there in the corner. Next month, we'll wrap up this year's series not on a Tuesday, but on Thursday, April 21st. We'll welcome Dr. Jenna Davis from Stanford University, who's an internationally known researcher on the connections between dirty water and global disease. The members of her lab call themselves the Poop Patrol. So I hope you'll come hear her tell us all about that. That will be Thursday, April 21st. Tonight, as usual, we'll have a reception following the talk right next door at Demosthenian Hall. That means food and drink. We'd love to see you there. You'll have a chance to talk with our speaker. We're really, really thrilled to have with us tonight a special guest, and that's Dr. Steve Kogan from the College of Family and Consumer Sciences, who has just been awarded a $2.1 million grant. That is a very, very nice amount of money from the NIDA at the National Institutes of Health to do a key study of the spread of HIV and other sexually transmitted diseases among rural black men right here in Georgia, a vastly understudied area. And in the press release about his grant, Dr. Kogan said something that struck me as so right on target for tonight's topic. He said, really understanding sexual behavior requires understanding a person's life in total. So with that, let's bring on Dr. Kogan, and he'll introduce our speaker.
Thank you. It's my pleasure to introduce Ms. Dázon Dixon Diallo, who will be the speaker tonight. Ms. Diallo is the founder and president of Sister Love Incorporated, established back in 1989. This is the first HIV/AIDS organization in the Southeast United States focused on women. She's an adjunct faculty member at Morehouse School of Medicine's Master of Public Health program in Atlanta. She is a founding board member of Sister Song Women of Color Reproductive Justice Collective and leads or serves on many committees focused on addressing the HIV epidemic locally, nationally, and internationally. This includes chairing the Fulton County HIV/AIDS Services Council, the steering committee on the Global Campaign for Microbicides, and co-chairing the Community Advisory Board of the Hope Clinic, Emory University's HIV vaccine and microbicides. I'm not a public health person, so I have to work on my obicides pronunciations. So, and I plan on doing this myself next time I'm in Atlanta on a Thursday, but tune the dial to 89.3 FM, and you will get to hear a weekly broadcast that Ms. Diallo hosts called Sisters Time, so you won't want to miss that, a program focused on black women. Ms. Diallo has pioneered program and policy initiatives in the women's HIV/AIDS and reproductive justice arenas. She helped develop a seminal prevention intervention that is now part of CDC's National Compendium of Evidence-Based Programs. She established the first transitional housing program for HIV-positive women and children, and she has developed a long-term vision for HIV-positive women's leadership in the fight against HIV/AIDS, promoting women's rights. Recently, well, actually not even so recently, 10 years ago, she's taken her mission to South Africa, where she opened a Sister Love program office to enhance capacity building and sustainable development for local women. She has received numerous awards and recognition over the course of 25 years working in this area. She holds a master's degree in public health from University of Alabama at Birmingham and a bachelor's degree from Spelman College. So please help me welcome Ms. Dázon, Dixon, Diallo.
I dare any virologist in the room to dispute me when I say every time you get a hug, you grow a T cell. Well, thank you, Steve, and thank you, Pat, and thank you to the entire UGA family for inviting me up this evening. I am really happy to be here, although I will tell you, 316 is a booger bear, and so I'm still decompressing, and I'm in the middle of grant deadlines, and so if I start speaking in goals, objectives, aims, methodologies, evaluation, y'all just say, grant, and I'll stop. No, I'm just kidding. My plan to talk with you this evening, because it is evening, I thought about, I could tell all of this work we've been doing in terms of developing our evidence-based intervention, but it's just so geeky and sciencey. So I wanted to really bridge all of those different things that Steve just explained or just described to you in terms of the work that I do. So I really wanted to bridge things for us this evening, not just in terms of the science that we put to figuring out ways to resolve this epidemic around HIV and AIDS, but as you saw in that opening video, what is the effect, the people's effect? In this particular instance, and for my talk tonight, the women's effect and what it means for us. So I really wanted you to see that video because while it just tells a micro of the experience of the things that are all connected to protect women's lives, starting from girl child and girlhood all the way until aging and to the end of life, that there's so many intersecting issues of which the core usually is around sex and sexuality and sexual health and sexual expression, that I wanted to be able to locate the work that we do in HIV inside a much larger framework. We happily and fiercely identify with the human rights framework, and then how reproductive justice is connected to that, and then just to talk a little bit about the programming that we do. And I just said all of that because I ran out of time to do my outline slide. So is that okay for tonight? Okay. So I just, a lot of people know all of this stuff already, and some of this is a little busy. I don't know if you can see it all the way in the back. But the bottom line is I want to start with the big picture and make it come a little smaller. And the fact of the matter is, where I really just want to hone in, is that while we don't necessarily recognize a women's epidemic in the United States, because women pretty much are less than a third, which is still a big number, but less than a third of the HIV epidemic in the United States, we're more than half of the epidemic in the world, close to 60%. And that's just another way of looking at it in terms of adults and children living with HIV as of 2009, according to UNAIDS. And you can't see the blue, but that's all the different sectors of the world. And what's most important, obviously, is this segment right here, which is sub-Saharan Africa, boasting over 67% of the epidemic. And North America is right in there, representing roughly around, and that's US, Canada, representing roughly around 4% of the epidemic in the world. Now, that's relevant looking at that 4% and that 67%, because in my world, if you only looked at African American women and or African American and Latina women together, we would look like 60+% of the epidemic among women in the United States. And so there's an equal parallel there between the experience. And this is another way to look at how we invest in that. So this is just, and I say that because a lot of the work that we do is the numbers that we are able to identify, the women that we're able to count, turns into what kind of resources we're going to need, right? And in this instance, here's North America on this line right here. What you have is, and this is by budgets, in terms of the representation in a given region. So this is not saying that 31% of the US budget on HIV and AIDS goes to women. It's saying that 31% of the countries in North America give this much of their overall AIDS budget to women, and the red lines are men, and this line right here is sub-Saharan Africa. If you can see the distinction and where the resources go, it sort of, kind of, almost follows the epidemic. This one is more stark for me and for all of us, I'm hoping, in the room, because almost half of all the HIV and AIDS cases in the United States are in the lower 14 states plus DC. So the epidemic is Southern. The epidemic is concentrated in the South. And if you can tell by the colors, Georgia and Florida are usually running neck and neck with each other. This is another way to look at the epidemic among women in the United States. Just simply put, this is by region: Northeast, Midwest, South, and West. And what does this tell you in this pink line is that Black and African American women in the South outnumbered by 4 times all the women in the rest of the region in the country put together by regions. Is there a collective sigh in the room? That's our struggle. And so this is just another way of putting that story together, that deaths in the South rose in the earlier part of the 2000s, and that's still continuing. I will throw my little political caveat in here, the fact that we have most of the waiting lists for people who are trying to get access to their medications. The South, especially Georgia and Florida, occupy more than half of the people in the country who are waiting to get their meds or are on waiting lists to get support for those meds. That number will begin to rise if people don't get access to care. And that, of course, 40% of all the American people living with HIV are in the South, and then some of this other data about how bad it is in our region. And I must say, I talked about 50% of the epidemic being in the South, but less than 20% of the resources come to our region. And if we came right on down to our fair state, Georgia has always ranked somewhere within the top 15 states. We have been always 8th in the nation in terms of HIV/AIDS rates cases in the Black community. Atlanta has always been within the top 15, often in the top 10 in terms of that metropolitan community of metro areas that are battling the burden of HIV and AIDS in our Black communities. And this is just another way of looking at where it's concentrated in Atlanta, although as of 2010, where you see Cobb, DeKalb, Fulton, and Gwinnett counties representing 11 times higher Black women compared to white women, Clayton County has actually reached the #1 spot in the state of Georgia in terms of cases per 100,000. So I locate HIV in the human rights framework. And it's because if you just check Eleanor Roosevelt, she says at the time, just after 10 years of working to develop the Universal Declaration of Human Rights, in small places close to home, so close and so small that they cannot be seen on any maps of the world, yet they are the world of the individual person, the neighborhood he or she lives in, the factory, farm, or office where they worked. Such are the places where every man, woman, and child seeks equal justice, equal opportunity, equal dignity without discrimination, and unless these rights have meaning there, they have little meaning anywhere. And Martin Luther King also echoed that. So what are human rights? And I start here because when we start talking about HIV and the intersections in people's lives, everything comes back to whether their dignity and their right to self-determination is protected or if it's violated. Human rights are universal legal guarantees protecting individuals and groups against actions that interfere with fundamental freedoms and human dignity. And we have what we call the International Bill of Rights. So there are protective documents out there that exist. The challenge, of course, is just like any law, how do you implement, how do you enforce, and how do you reinforce so that it's sustainable over time and actually somehow changes society's approach to some of these issues. First, you have the Universal Declaration of Human Rights. Y'all can go and get all of this stuff online. And you can read all of these things. But the Universal Declaration of Human Rights is a vision statement, just like we know about another declaration, right? That says something about you've got the right to pursue the, life, liberty, and happiness. And then we went to the Constitution, and there's nothing about happiness in your Constitution. So it is a vision statement, and then it gets backed up with these two laws or bodies of laws, the International Covenant on Economic, Social, and Cultural Rights, and the International Covenant on Civil and Political Rights. Both of these are extremely important for a lot of reasons. And I'll just digress just for a moment. We've got a discourse going on right now about Libya. And I don't believe I have heard in 1 week the word genocide in this country more than I have heard in this past week. And it's not so much as that's what's happening in Libya by proof, but we have a memory that is stamped on us personally, politically, economically, and geopolitically that reminds us of the opportunities we've missed in the past to protect the people. And these documents were put in place in somewhere between 1948 and the 1960s to ensure that. So that's why there's this debate going on, because now is the one time where we said we can get in front of this before anything happens, but people are still concerned. So when I talk about the human rights framework, there are lots of pieces that come together in it, and they all work together for a reason. You know, most of these we're most familiar with are civil and political rights. And what are civil rights? They're very, 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 very simple. It's the right to be treated equally under the law. That's it. Now, you can break it out in terms of voting rights, that's political. You can work it out in terms of employment in the workplace, that may be economic. But it truly is just the right to be treated equally under the law. But here you got a problem. If you don't have your economic rights, your social rights, your cultural rights, your political rights, the way I quote it is, all you have is the right to be treated equally as bad as everybody else, right? And so you need to have all of these protections in place and lined up so that you can address disease, you can address violence, you can address political representation, you can address movements, and you can also address social change. We also include sexual, developmental, and environmental rights, along with some special rights around immigrant, refugee, and indigenous people. And I get to the point that when you look at where HIV lives the most, it's where people who do not have access and protection to most of these rights live. And that's why I locate HIV in human rights. So why? Because they're fundamental to any response to HIV. Human rights and public health actually share the common goal of promoting and protecting all individuals' well-being, and that rates are disproportionately high among groups who experience the lack of protections. Are there any questions about rights? Because I'm not going to come back to that. I just want to make sure, because usually that sparks debate about whether they're real, whether they're attainable, whether they're achievable, whether we even have them. Anybody think we have them? Yes, no? No, yes? You're in a chapel, call and response. Yes, no, have we achieved the human rights paradigm? I would say not. So that was my question for you. Thank you. So you heard a little bit about Sister Song. I am a member of Sister Song, and my organization, Sister Love, is a founding member of Sister Song. And why we got involved is simply because we recognized from a gendered lens that there were many issues impacting women here in the US and around the world that were not being addressed simply because HIV was not being addressed through a reproductive rights or sexual and reproductive health lens. And so with Sister Song, we created a network of more than 80 women of color and allied organizations, individuals collaborating together on this notion of reproductive justice. We consider it a collective movement for sustaining and mobilizing women of color and our organizations around critical issues that go beyond issues of abortion or go beyond issues of contraception and family planning, because the choice matter is a non-choice when you cannot afford it, when it's not accessible, when it's not available, and maybe even when it's not the appropriate type of care you need. And so justice takes on a different connotation when we're talking about addressing those lacks. And of course, because we really didn't even have, from the 90s up, and even before that, we never really had a collective voice of women of color in the movement to protect women's reproductive health. So when we talk about what the core principles of reproductive justice are, and this is, I know it sounds out there, but it's actually immediately relevant to the lives of women and girls with HIV every day. So our first notion under reproductive justice is that women have the right to decide when and if they'll have a baby and the conditions under which they'll give birth, decide when they will not have a baby and the options preventing or ending that pregnancy, and to parent the children that she already has with the necessary social supports and safe environments, healthy communities, and without fear of violence from individuals or the government. And so we consider reproductive justice based fundamentally on the worldview on human rights. It links individuals to other communities and in their own communities. We use an intersectional analysis. I just choose to spell sex in the middle of mine. And we define the primary problem as reproductive oppression, which we could go through a whole long list, from forced sterilization to denial of comprehensive sex education to the attempt to wholesale eliminate family planning and contraception from our U.S. budget. All of those issues are all connected to whether women have the right or the ability to self-determine their own reproductive destinies. And so it's about whether we have the right to determine what happens to our bodies, whether we can determine our own self-determination, that we actually have the opportunity to work with other social justice movements. And this has become critical because I talk a lot these days, especially in the global context, around the pending end of AIDS exceptionalism. And why is that pending? Simply because when you work within communities that have all of these different issues going on, you really have an onus to figure out how to make HIV non-stigmatized and how to normalize it in the face of the other issues that people are addressing every day. I don't know how those got in there twice. So how we consider who is most at risk, you could probably come up with any group. If any of you are volunteering or in community service or working to improve the lives of people who are less advantaged or less privileged than you, they're in this list. Women, children, people in poverty, immigrants and migrants, refugees, people who are internally displaced. Any people from New Orleans here? Minority groups, people with disabilities, prisoners, detainees, sex workers, people of the LGBTQ or sexual minority community, indigenous peoples, injecting drug users, and I'm sure there are others. So, I'm gonna keep going. So how we put HIV and human rights together in the work that we do in Sister Love is under three main categories. It's about accountability, it's about advocacy, and it's about what type of programming you're able to create that will move people further down the road to achieving these protections. In terms of accountability, some of the rights within the human rights framework that are immediately relevant to HIV and AIDS, first and foremost is non-discrimination and equality, access to health, liberty and security of person, privacy, being able to get the information that we need, to marry and found a family. Now that sounds odd because people have their own perceptions and perspectives on whether people with HIV should even be having sex, much less having children and creating families. But they are human beings with an infection, so that right should never be limited to them or away from them. The right to work and the right to move. I think what's interesting is it was in 2009 when the United States, after 23 years of banning people living with HIV from receiving visas to come to our country, that we lifted that ban. That very ban alone was a human rights violation. And as a matter of fact, by lifting that ban for the first time in 23 years, the International AIDS Conference is coming back to the US because they refused to come to the US until we fix that little problem. So in terms of accountability, and it's real basic in terms of our government's obligations, regardless of what the policies are, they should be intended to respect those rights, to protect those rights, and to fulfill those rights. So it's not enough to pass a law to protect people's access to health care. It's more important to make sure that that law is implementable and that it can be fulfilled and accessible to people. Now, from my perspective and the work that we do at Sister Love, these are some of the key policy platforms that we work with, that we study hard, and that we make sure we have something going on in our programs that addresses these key policies. The Bill of Human Rights, which is that triumvirate of issues in yellow that I pointed out earlier. CEDAW, which is the Convention on the Elimination of All Forms of Discrimination Against Women, which has been ratified in over 180 plus countries. The United States is one of maybe 3 industrial countries. Yeah, the only industrial country remaining that has yet to ratify this convention. The only other two, I think, are Monaco and San Marino, which are basically castles, right? I'm just saying. The Beijing Platform for Action, which was a major document that came out of the Fourth World Conference on Women in Beijing in 1995. The Millennium Development Goals, which were a follow-up to halving poverty, making poverty in half or cutting it in half by 2015, of which at least 3 goals are specific around improving the lives of women and girls around the world. The Global Fund to fight AIDS, TB, and malaria, the U.S. National HIV/AIDS Strategy, which was just released for the first time ever in the United States in 2010, and understand we're 30 years into an epidemic and we finally have a plan for how to address our own issue. The Ryan-White CARE Act, especially ADAP, which is the AIDS Drug Assistance Program, of which right now there are over 7,000 Americans on waiting lists waiting for the assistance to get the medications that they need. Over 1,000 of those 7,000 are living right here in Georgia. And the Patient Protection and Affordable Care Act, which is also known as health care reform. Why is that important to us? People with HIV have pre-existing issues. People with HIV belong in high-risk pools in a lot of places. People with HIV tend to be more eligible for Medicaid and Medicare, all 4 areas of which are guaranteeing better support in the new act that we have. Implementation is key. And in terms of advocacy, we look at the process of mobilizing community around our issues of concern, and these are just some of the examples of advocacy. If you ever go meet with your government official, with someone you elected, to tell them what you need and what you need changed in your community, or if you do social media projects, or work with media, or create PSAs, have a celebrity on board to speak the messages, all of these are just different examples of advocacy that we try to engage in. And for Sister Love, this is our most critical area. How do we take on a rights-based approach to make sure that we're helping guide the needs and rights of the community while we are simultaneously working to empower those same communities to broaden their own participation, strengthen their own relationships with the law, with policymakers and partner organizations? People go, ooh, Dázon, you've been doing this so long, you just must be out to save the world. How many parents have told you all that? And, you know, I told my parents back one day, I said, well, you know, I'm not out to save the world, but I am out to change the world so that it can save itself, and that this is what this process is about. So in terms of approaches to our programming, we want to ensure that there's no discrimination, that there's equality, and that there's full participation of the community that we involve.
Why is it that no matter where you go on this earth, no matter how many or how few women of color there are in any given country, where there is HIV, we are impacted? If we draw back the lens on just what it means to be a woman of color, we've already got vulnerabilities. There's already gender inequity, and there's still racial and ethnic inequity and discrimination and otherness about who we are. So if you already have all of these differences going on, the impact of an entire community by HIV when its women are impacted already looks different. Where the larger sectors of community meet and need services, women are the ones there to deliver a lot of that. In terms of family, in terms of community management, that for me is how it's different. When you strike a woman, you literally are striking the whole community. And that changes the paradigm of how we need to address HIV. You want to start the travel stuff on the phone, that's fine, but in that letter you can put, anytime we give space and opportunity to tell our stories, then that helps someone else, and it helps ourselves. The title of this series is not by accident. We work on the premise that everyone has a story, and there's a lot to be respected and learned and honored about every one of our stories. This series is so important because these are some of the most unsung sheroes that I could ever put on the front line of this epidemic, who are doing this fight in their own lives, but also in their communities every day. I hope that by sharing their stories, and the women that are featured in this series, helps women start to share their stories everywhere.
We have a new project called Everyone Has a Story, which is wrapped up in all of that I just talked about, that every single woman living with HIV has a story. And it's a real one that if you just give a chance to the voice and to listen, then there are solutions in those stories. There are more questions for what we might research in those stories. There are accessible connections and solidarities that other women with HIV find in those stories. And so we're very proud of the bravery and the engagement that the Positive Women leaders that we've been working with took on to put that video, or to participate in producing that video with us. You can find them at sisterlove.org. They're on our main webpage. So here's our mission, and here's a little bit about who we are. Sister Love is now 22 years old come July. We are based in Atlanta. We work around the state of Georgia, but you know Atlanta is a big county area. We almost include Clark County. I'm sorry. We have a small staff. We say we're a small organization that does a lot of very big things. We serve over 5,000 women, men, and youth a year. We have what I call 2+1 office locations, 2 in Atlanta and 1 in South Africa. And we work with just over $1 million, which is not nearly enough to do all the super big things that we do. Our main program areas are in health education and advocacy, an area that we call Bridge Leadership. That would have been the other title of my talk tonight, would have been called A Bridge to Solidarity. Because where we do our work is around making sure that HIV is consistently integrated and intersected to other issues that have impact on women's lives that may either impede, right, or enhance women's opportunities for living healthy lives. So, for example, we have an intersectional HIV and violence prevention intervention that we call RISE. We do work on behalf of women who are dealing with comorbidities or co-diseases such as mental health, substance abuse, homelessness issues, that we want to make sure we're bridging advocacy and programming in all those different areas. And we teach on college campuses in the community. So we teach courses that are regular, unit credit courses, but students come to us and take their courses with us in the fall and in the spring. And then we have an international program in South Africa. In terms of the health education and advocacy program, these are all of the different types of things that we do. All of them are different interventions or areas where we are involved with networking and partnering, because that's the other part that's very important to address these critical issues. I lift up the Healthy Love Party because there's just a quick story in that's a homegrown, women-created intervention by women in the community, for women in the community, back in the late 80s. When the Centers for Disease Control came up with the program plan of creating what they call diffused evidence-based interventions, which basically means we go and we test these interventions, we do long evaluation studies on them, and then we turn them into boxed interventions that are supposed to be addressing specific populations. Well, the problem we had with that model was that for general populations of black women at risk, there was only one. And I'm never going to walk in a shoe store and look just for one kind of shoe. I need that whole variety, including the sales rack. And you're not going to go into a restaurant and look at a menu, and if they only have burgers and fries, then that's your option of what you're going to feed yourself with. What happens if I'm a vegetarian? So to have that one intervention available for so many people in different communities from different walks was not acceptable, especially when we had one of our own. So we engaged in our own long-term evaluation study. I call long-term 5 years from a community-based perspective. I know it's not the longitudinal, but it certainly wasn't a rigorous evaluation study conducted by community, created by community, implemented and studied by community, which lifts up the fact that community-based participatory research has a major role to play in developing and evaluating and delivering workable, effective, and evidence-based interventions in our own communities. So we're very proud. You can get the paper. It was published in AIDS and Behavior last summer. So we are very proud of the fact that we now have our own intervention that is also now included in the National Compendium of HIV prevention programs that work for women. And we are about to work with the CDC in South Africa to pilot and roll it out in communities of women in South Africa as well. Once we can show that it's replicable, then it just becomes another part of the overall prevention toolbox that people have more choices to work with. In our Bridge Leadership Program, because we recognize the digital divide in the neighborhoods where we work, we have established the Positive Connections Cyber Center, which is a free access computer center to train and help people access whatever they need on the information superhighway, which I know is so 80s. The Positive Women's Leadership Project, which focuses intently on making sure that women living with HIV are capacitated to take the role of leadership, to speak, to advocate, and to be an influential part of what happens in their lives around HIV and AIDS. Our most recent initiative, which is the 2020 Leading Women's Initiative, which we are also rolling out internationally for the first time this year in South Africa, is a special program that focuses on women who are already community leaders, actively involved, not even only in HIV, but actively involved in social change work in their own communities and have been living with HIV 20 years or more. And the age range of the women that we have awarded and have included in our initiative so far is 22 to 79. Okay, that was another video that was supposed to happen. Bingo. But y'all can get that where? I'm just checking. So I want to just talk a little bit about our work in South Africa as well. Now, it's different, but it's not. It's different in the sense that we don't do the same work on the ground in South Africa up to this point simply because we're not South African. And it wasn't my expectation that we would be able to deliver the same services in the same way that we are able to do it from a community perspective in our own communities. So what we do is we link up with women's organizations and women's serving organizations on the ground to help build their capacity and their programming to meet the needs that they've determined for themselves. One of the projects that we are most proud of is how we've bridged together the idea that for the sake of being financially dependent on partners or on families, which is the same story here, or living in cultures where women are more or less property, for lack of a better word, where women don't have the options of who to marry, or when and how to get divorced, or if they choose to get divorced, how much shame they bring on their own families. In South Africa, we have still this little problem called lobola, which in our understanding would be a bride price, which usually translates to cows, but not everybody in the city wants cows anymore, so it translates to cash, and that the pretending husband has to have enough cows, need cash, to actually give the family of the bride before they release her to him and his family, because that's basically what happens. Imagine how hard it would be to get out of a violent situation when that transaction has happened. Imagine how hard it would be to negotiate condom use in a country where in certain provinces about 49% of the pregnant women are already HIV positive. Imagine how hard it would be for a 12 or 13-year-old to negotiate anything around her health when she has already been placed into marriage in someone else's family. These are the critical issues that bridging economic development and economic independence with ending the risks and the vulnerabilities to HIV and AIDS pose to us in South Africa. So several years ago, we developed a cooperative of women's organizations and the individuals who serve them. Because see, like a lot of folks, you know, we volunteer a little bit because we got jobs, right? Because something else is paying us, or we have other means of income that make sure that we get food on our table and we have lights over our head and that we can put some clothes on our bodies and maybe get across town. Well, we have this phenomenon where unemployment is so high that most people who are working in the rural sector, especially in HIV and AIDS and other social change organizations and charities, volunteer full-time like a lot of people get up and go to work every day, all day, with no compensation, no stipends, no salaries, Nothing, because the organizations don't have these things. So we wanted to figure out a way to how to sustain those women's groups and help those individuals as well. And we didn't have immediate access to microfinance projects at that time, but we did have access to the land reform policies that were at play in South Africa. And what I mean by that is that the government is undertaking a very deliberate, very long process to restore land rights that were taken away from Black South Africans during the height of apartheid. Wholesale, just move off your land, and it was then appropriated by some white man or some white family, and then handed down in his family for generations. So we worked with the land reform through the Willing Seller, Willing Buyer program, and with these individuals in these organizations, we managed to transfer a 700-acre dairy farm from the hands of one white farmer into the hands of a co-op that's made up of about 60 individuals. So now, we milk cows to fight AIDS. The real deal is that we are able to generate jobs, we're able to generate income, and we are able to make use of land to deliver other services. We are currently in the process of developing a training program for other emerging farmers, and we are in the process early on of planning and hopefully implementing a primary prevention clinic and educational site on the farm for our local neighboring communities that are about 95% single-headed households, female households. So I'm actually gonna do one more Girl Effect video for you and then entertain questions and that sort of thing, because I'm coming to the end of my talk and want to spend the next of our 15 minutes or so just anything that I've sparked in your mind, any questions you might have, that we can just talk about that. Is that cool? Okay. So I was really taken by these anybody ever see these videos before, the Girl Effect? Aren't they awesome? Yeah, I agree with you. Just to close, again, I wanted to sandwich my talk between those two videos because that really is the thrust of what I mean when I talk about locating HIV and any other critical life-threatening issue, whether it's maternal mortality, whether it's vaginal fistula, whether it's malaria, tuberculosis, whether it's any particular issue that, but for changing the conditions in which girls, women, boys, and men have to plan their lives, that we could actually end a lot of these problems. And this is why I located in the human rights paradigm, because that's exactly where most of these problems exist. I really want to thank you for listening and for coming this evening. I could not come here all the way from South Africa without bringing a little bit of Robben Island with me. If you have questions, if we want to take some comments, I am so open to that right now. You just don't know. Thank you all for listening. And again, Everyone Has a Story videos, there are 5 different vignettes that are focused on stigma, shame, disclosure, on family, friends, and networks, on patient-doctor relationships, which are actually helpful for a lot of us, not just for people with HIV, and access to care and treatment. And again, you can get those online at sisterlove.org.
Was that the first question?
Yes, ma'am.
So we have the Global Fund, we have PEPFAR, and there are others that are supporting HIV/AIDS abroad. And you cite that there are people on waiting lists in this country to receive antiretroviral drugs. So
yes.
What's happening, and how do we make both of those things happen?
Brilliant. It's interesting. Yes, we have PEPFAR, but that's also under threat. That the commitments to PEPFAR are not being met currently, and as a matter of fact, most of the commitments that even President Obama made to PEPFAR are not being met, and they're actually drawing back on those original commitments, and that's sending a weird signal to the countries around the world that are contributing to the Global Fund. So there are some real challenges there. But we are up against the wall right now in terms of the economy, in terms of the political footballs that are being played with specific issues like health care, like education, like jobs. That all of these things right now seem to have a negative net effect when we're talking about people dealing with our current appropriations process. And so we got a national AIDS strategy. The idea to have a national AIDS strategy was to at least have a plan that had some targets that would require a specific amount of resources to address those targets. Now, as things usually happen, what goes into negotiation is not usually what comes out, right? And so we are still way behind on our commitments. I don't know what's going to happen to Ryan White, the CARE Act, going into the shifting of funds into the Affordable Care Act. I don't know what's going to happen in terms of the uber medicalization of HIV as opposed to the larger complexities of all of the ancillary issues that people have and the needs that they have. So right now, for example, Ryan White is up. All the applications are in for CARE Act money, which is all funding that pays for HIV/AIDS services to indigent or poor people living with HIV who have no other means of access to health care, but it also includes all kinds of things like case management and mental health and substance abuse and housing and food for people who can't care for themselves, transportation, all of these issues that help facilitate accessing health care is under threat. We are probably, as a matter of fact, the first bill or the first budget recommendation coming out is set to cut Ryan White. They're setting to cut HIV prevention funding with the exception of some specific new projects. They are set to actually, even in the state of Georgia, wanting to cut ADAP when we have the second highest ADAP list. So where we are is in the need to do two things. One is to raise the volume on discontent in communities where these issues are not being talked about enough, that we need to understand how the funding works and where it's creating problems. And then two, we need to be able to continue to draw the parallels between what's happening, especially with men who have sex with men and with Black or African American and Latino heterosexual communities that are actually paralleling what's happening in the rest of the world, especially in sub-Saharan Africa. I'll give you a good example. A couple of years ago, the Black AIDS Institute put out a report called Left Behind. And all they did was create a scenario in which if Black America, you know, all 30-something million of us, if Black America was its own country, how would we stack up in terms of the epidemic? We would be the 16th most populous country in the world with the HIV epidemic, which would make us eligible for PEPFAR, right? Washington, D.C. is currently our epicenter. The prevalence rate of HIV in Washington, D.C. is somewhere at any given time between 3 and 5%, which exceeds almost all of the incidence and prevalence in West Africa, of course in North Africa, and in parts of Central Africa even. We have a parallel experience here that is not being given that same level of attention. And so we've just got to fight. That's all there is, because they are aware of the problem, but nobody is beating down the doors, literally in numbers, because communities that are not directly involved in HIV and AIDS, honestly, are leaving it up to those of us who are in HIV and AIDS. And that's just not enough to make a big difference. Does that make sense? In other words, other people have to care about that issue, because if we get more attention, if we get more resources to HIV and AIDS, then that means we get more resources for comprehensive sex education. That means we get more resources for better access to health care. That means we get better opportunity to prevent disease as opposed to only treat disease. But we don't make those connections every day because we have isolated HIV and treated it as its own, like I said, exceptional issue, which has a place and had a purpose for being exceptional. That's the only way we got attention in the first place. But now we have to figure out how to make it real for everybody who doesn't just say that that's about somebody else. Does that make sense? Thank you for the question.
How do we mobilize communities beyond the national HIV/AIDS awareness day?
So there are a couple of things that you can do. First of all, thanks for coming tonight. That's one. Two is there are different ways to have conversations about HIV and AIDS. You can mobilize communities literally like our video series, and I'm not just touting that because I'm shameless about it. But like our video series is going to come with a slide deck. It's going to come with a very simple, easy facilitator's guide that you could just have a girls' night or a friends' night or a people's night and just show the films and then talk about that. You can mobilize people around that. You can join different listservs. The Georgia Equality Foundation has an amazing policy listserv that keeps us abreast of what's happening at the state and federal legislatures around these issues and puts out calls to action on a consistent basis. We have a new initiative called Act Now, which is also on the website, which is mobilizing HIV-positive people and their allies to fight for better support for ADAP in the state of Georgia. The Sister Song Reproductive Justice Collective has an amazing array of information that comes out once you become a member on that website as well. I would put out there that Let's Talk About Sex 2, which is our national conference on sexual health issues for women of color, will be happening in Miami. That's supposed to be attractive. Will be happening in Miami in July, except for those people who can't stand that kind of heat. We'll be in Miami in July, and it's usually we're probably going to have about 1,500 people there who are doing the work and building capacity and mobilizing communities. On April 8th, as the United Nations meets for their global AIDS strategy, they're having a huge NGO meeting. If you can be in New York, if you know people in New York, you talk to them, you Twitter them or tweet them, or y'all know the lingo, or you Facebook them or call them, shoot. And support them to get to the demonstrations that will be happening on that day to raise the level of concern not only about the Global AIDS Fund, but also about US. And I'm seriously encouraging people just to stay in tune to even what's happening on a day-to-day basis in your own communities around your local aid service organizations, your local women's and youth service organizations, that there are places to not only volunteer, but to help mobilize and organize to get people to the different activities. We got a van just primarily for the purpose not only of being able to get people back and forth to services, but to be able to load people up and so they can get to the next presidential debate and make their voices heard. And we do that on a consistent basis. We send folks to DC who are living with HIV and their caregivers and their allies to meet with their local or their congressional representatives. These are the kinds of things that we need folks to get more involved in. Blog about it, talk about it, stir up the communication, stir up the conversation, and have activities on your own, in your house. That healthy love party I talked about, the prevention intervention, we come to you, your house, your dorm, your hall, your church, your place of work, your community center, wherever you and your folks are most familiar with each other and comfortable to receive this information and to talk about these issues in a deep and meaningful way, we come to you. But they're very fun. They're very fun.
That's a great list of things that we can do. We also can continue this conversation next door. We're food and drink and fellowship and sisterhood all the way. Thank you so much for coming.
Thank you all so very much.